Yes, so welcome everyone.
Thank you. Good afternoon. First, I would like to say thank you to the Diczfalusy Foundation for organizing this kind of meetings with a different subject in gynecology and perinatal medicine and give us a continued education through these corona breaks. I wish all of you, dear colleagues
Hello.
and friends, a very warm welcome.
Hello, sorry for the late. I had also the same problem. Now I'm on the phone. Okay.
We are trying to sort it out now. There's Microsoft Teams, we are opening. Allow. I checked the name, Suju. Nikolai Suju.
Just.
Okay. You know, that's me starting.
Ivan, shall we continue? Ivan? Oh no, I think we have to continue because this is a problem with the other speaker, and now in that case it will be an endless situation.
Okay, once again, good afternoon and welcome to all participants, hoping that we have more during the lecture. It's my pleasure to moderate this webinar, and I would like to introduce our first speaker, Professor Dieter Bettelheim from Vienna Medical University. He's expert, as we know, in the field of perinatal and fetal medicine. He's well known all over the world, especially in this part, in this region. And quite often he's so kind to give us a different lecture. And for these years, we learn a lot from him. So I would like now to invite him to give his lecture about prenatal diagnosis of fetal abdominal malformations. And floor is yours. Enjoy.
Yes, I tried to open my file. You can see my files?
No, there is nothing.
Okay, one moment.
We can see you now on the camera.
Yeah.
But no slides. No.
Laptops, but it's still a problem with pentru că dacă asta e făcută cu trebuie să intru, dacă eu mă duc pe WeTransfer, îi trebuie să descarc la mine, dar trebuie nevoie de e-mail, asta să deschiți mail-ul.
Ivan, there is no slide.
And now also no presentation. One moment.
There is no slide.
Nothing?
Nothing?
No, nothing.
We tried it a few minutes ago, and at this time it worked. But now it should work.
Yes.
Ivan, nincsen. Aha, most már megjött.
Please.
Megjött.
Okay, now everything all right.
Okay.
You see the first slide?
Yeah. Perfect.
Excuse me, can you see my slide?
Yes, we see your slides.
In presentation mode.
No, in editor mode, but it's quite big.
Okay. And I can start with my lecture.
Yes, please do.
Good afternoon, ladies and gentlemen. It's my duty today to talk about the fetal malformation, which give special respect to the fetal abdomen. when we look back for more than 200 years, it was very easy, because at that time, being pregnant meant to be in good hope, and to be in good hope meant to expect the possibility of a good outcome. But today, it's completely different. After ultrasound was invented in the late 60s of the last century, a big evolution took place. And today we are using very high sophisticated ultrasound machines where brilliant pictures can be produced from fetuses inside mother's belly. And the situation today, the ultrasound machines allow us to perform baby TV, which brings the mothers to high expectations, and wishful thinking takes place. Every woman which lays down on the bed thinks that everything will be all right. And every woman is in the opinion that normal ultrasound means that a healthy baby will be born. Sonography as a screening tool is very good, because sonography is harmless and cheap and reproducible and documentable and non-invasive. Ultrasound is not ultrasound, and we have a lot of different examinations. Two advanced ultrasound examinations, which means the first trimester screening between 11th and 13th week, and the fetal anomaly scan between 20th and 24th week. And at that time, a lot of important pictures have to be made, have to be stored to prove that the fetus underwent right development. The normal fetal abdomen shows the stomach, which is oval shaped.
Dieter, sorry.
Yeah.
Your slide is not moving. We just have the first slide.
Okay. It's awful, because I have been on the 15th slide at the moment.
We can see the third one.
Yes,
Yeah.
now it's on the third.
And you see it now?
Just the ultrasound equipment, machines.
Ultrasound machine.
Sure,
Now you
yes.
see situation today.
Is it possible
No.
for slideshow?
On the next is situation today in a small one, but on the big one we can see the two computers, or I don't know, machines.
Yeah. And what do you see now? Situation today?
No, at the bigger screen, we see only two ultrasound devices.
I don't know why, because on my laptop, I'm in the normal presentation. And if I press the button, one photo comes after the other one. I don't know why it does not work in the
Now the situation today. It's very slow. Okay.
Okay, now we have seen the fourth one.
Yes, situation today. Yes.
And
yes.
you see, this is, you can see now sonography as screening tool, then it does not work.
Yes, the next one, sonography and screening tool. Yes.
Okay, I cannot go to the big picture. I have to present it like this, okay?
Yes, it's perfect.
Yeah, if we have sonography as screening tool, we have to be aware of the fact that sonography is harmless, cheap, reproducible, documentable, and non-invasive.
Yes.
So ultrasound examinations are most important between week 11 to 13, which is the first trimester ultrasound screening, and the fetal anomaly scan, which is done between the 20th and 24th week, so that a lot of important structures of the fetal abdomen can be visualized at both time frames. The normal abdomen shows the oval-shaped stomach, which is on the left side distal to the heart, and the stomach is not allowed to cross the midline. The liver should be...
Yes, I can hear you, but it's a phone, so it's very weak, but it's on my side is the problem. Yes.
So the liver is of homogeneous echogenicity.
So I have the PowerPoint presentation. How do I share my screen? Because I pressed here Microsoft Teams, share screen, open share tray, and I have desktop screen.
Yes, please give him all the information
of Windows.
without disturbing the...
Yes.
But it doesn't share.
My presentation.
Please let Professor...
Coming. Something is coming. Wait. Yes, I can see.
Professor,
yes, I can see your presentation. Yes. It's in editor mode, but it's okay. We can read it perfectly.
Okay, we can read it perfectly. Okay, yes, slides are working. Yes, it's good.
It's yes, working.
I go on with the... Hello.
If you want more, no, okay, it's okay.
So just tell us when we are live and we present.
So it's working perfectly. So please come to the other room where is the real presentations. Okay, and after finishing, you can come.
I would like to continue with my presentation.
Just a moment. Again, hello.
But it does not work when someone else is influencing me.
Elpróbáltuk, de nagyon rossz neki a net kapcsolata. Csomószor lefagy a kép, meg minden. Tehát
Professor Bartfej,
vagy a gépe, vagy az internetje.
Professor Bartfej, please mute your microphone and let Professor Dieter...
Nem tudom, ez nála van valami. De most a románokkal mindjárt végzünk, mert összeraktuk, így, hogy jönnek ők is. Ott meg még nagyobb galiba volt, majd elmesélem.
Okay, so please let us know when it's our time to present. Around what time?
Sorry?
When we are going to present, when we should present.
Okay, I will send you the link. Just a moment. Didn't you get my email? Did you get my email before? With the link you should have, because I sent this link to you.
Yes. Okay.
Okay. Everything is okay.
Do you hear me?
Yes, now can we hear you?
I continue with my talk about normal fetal abdomen.
Yes, it's the actual slide, normal abdomen.
Yes. If we take a look at the fetal liver, we have to take care that the echogenicity is homogeneous and the intrahepatic umbilical vein is J-formed. The bowels should normally show no dilatation, and the echogenicity of the bowel must be less than bone. Here you see the pictures to the text I have told you before. This is the oval-shaped stomach on the left side of the fetal abdomen. This is the homogeneous, J-formed intrahepatic umbilical vein. This is the normal situation in a fetus in the 17th week, where you see the color-coded sign of the umbilical cord which enters baby's belly. Today we will talk about the major malformations, which are gastroschisis, omphalocele. We talk about duodenal stenosis, hyperechogenic bowel, and stenosis of the gut. The most important two malformations of the fetal abdomen. First of all, the gastroschisis. There is a paraumbilical defect. It is usually on the right side. The prevalence is 3 to 5 per 10,000 women. Young mothers have a higher rate of gastroschisis than older mothers. There might be an association to smoking, alcohol, or drugs. In 86%, this malformation is isolated. In 10%, we find associated intestinal atresia. And this malformation has a very small percentage of chromosomal anomalies. There you see the pictures of a gastroschisis in the 12th week of gestation. Also here, 12 weeks, fetal bowel free flooding in the amniotic fluid. In later weeks, the surface of the fetal bowel is changing. It gets a higher echogenicity, and also it might be dilated in some times. The ultrasound signs of gastroschisis are free-floating loops of intestine without a surrounding membrane, and there is a normal umbilical cord insertion. Very seldom, bladder, liver, and stomach are also exteriorized. Some additional pictures of gastroschisis. When we talk about the best time of delivering a fetus with gastroschisis, we are always in a big trouble when it is the best time, when it is not too early, when it is too late. And lots and lots of papers have been written about this question. And I will talk about a paper which was written in 2015. They divided two groups. In the first group, the identification for delivery was depending on a subjective evaluation of the small bowel diameter. And in the second group, certain limits for the small bowel dilatation and for the wall thickness were used. And both groups were compared, but they could not find any difference. There were no noticeable differences between the two groups regarding birth weight, centile of the weight, arterial pH, and small bowel diameter. The group 2 had a little bit lower rate of prenatal complications. In our everyday life, we see that sometimes the fetal bowel is dilated very much in cases of gastroschisis. In these cases, there is a bowel dilatation of more than 20 millimeters, and the typical echo-rich structure of the bowel wall. And in those cases, we often find polyhydramnion, because when the act of swallowing does not work perfectly, the secondary finding is a polyhydramnion. The dilatation of the fetal bowel can reach an amount where it is not so easy to wait. We are talking to the neonatal surgeons and we try to find the best time to deliver those fetuses. There is also another form of bowel dilatation in a way where we have two bubbles side by side, as you see it here. This is the so-called double bubble sign. It is duodenal atresia. It is has a prevalence of 1 out of 5,000 births, and it is very often combined with chromosomal defects, mainly trisomy 21, which takes place in about 30% of all the cases of duodenal atresia. This is very important when you see such a malformation, even in cases where a non-invasive prenatal test has been performed. Forget the first information, do a normal amnio afterwards to be completely sure what's the situation in this pregnancy. The second most important malformation of the fetal abdomen is the omphalocele. It is also a very common abdominal wall defect. It is, the incidence is 1 to 2 per 10,000 live births. It was the first prenatal diagnosis of such a case was reported in 1978 in the 33rd week of gestation. You can classify this malformation in small, giant, or ruptured cases of omphalocele, and the size of the defect and the severity of the associated anomalies determine the overall morbidity and mortality. The ultrasound signs of omphalocele are loops of intestine outside the abdomen, but in a surrounding membrane. And in this situation, you have an abnormal umbilical cord insertion. A giant omphalocele is existing when it is bigger, the herniated liver and the herniated sac is bigger than 4.5 centimeters. The rate of chromosomal anomaly is very high, 50% in week 12 and 30% in week 20. Also, the other malformations in this situation are very common, between 30 to 50%. Only 14% of omphaloceles are isolated findings. The routine screening and the identification of such an anomaly is important because you can bring the patient to a tertiary center for undergoing a safe delivery and for presenting the fetus to a multidisciplinary team of obstetricians, neonatologists, and pediatric surgeons. Here are some photos. Here, photos of our clinic, omphalocele in the 12th week of gestation. Also here in the, not in the longitudinal, but in the cross-sectional view, you see that the fetal stomach is very near to the place where the abdominal wall has its leak. They're very small. Omphaloceles are called hernia into the cord, and you are not you may not mix it up with the physiological omphalocele, which is physiological till the week 12, which means that the crown rump lengths below 50 millimeters may be affected or may be combined with the physiological omphalocele. After the 12th week or after 50 millimeters crown rump length, all the intestines have to be inside the fetal abdomen. This is a picture of the 18th week, and here you have a picture how an omphalocele looks in the magnetic resonance imaging. We are in a very good situation in Austria because our radiologists are very much experienced in magnetic resonance imaging of the fetus, so that all the pediatric surgeons are not waiting for our pictures. They want to have the whole fetus on one picture, which is possible in every week by using magnetic resonance imaging. If we want to ask which is there a parameter for prognosis of the omphalocele, how can we predict the cause of outcome? We have to know that the size matters. Omphalocele ratio can be defined as omphalocele diameter in combination to the abdominal circumference, and you can make two groups of patients, the patients which have a small or patients which have a high ratio of omphalocele abdominal circumference. And the difference is that a primary closure after delivery of the small ratio fetus is very common in about 60%. A primary closure of big giant omphaloceles is very, very uncommon. In this paper, you see 0% primary closure. So the days to complete closure is also very different. The small omphaloceles can be closed on the 7.5th day, and the large omphalocele need more than 500 days till a complete surgical closure is possible. Which means that the days of total parenteral nutrition and the amount of intubation and the days on mechanical ventilation is also very different compared to the size of the omphalocele. The omphalocele ratio is an effective tool in predicting postnatal outcomes, so important information can be given to the parents, but all in all, the method of calculating of the ratio is not so important. The key note is that a big omphalocele stays longer in hospital than a small omphalocele. And this is an information which is very easy to transport to the mothers. When the omphalocele contains liver, it is unlikely or impossible that it might be a physiological omphalocele and that there might be a normal resolve of the situation. Sometimes also the fetal urinary bladder is eventuated in combination with parts of the abdominal contents. The next malformation or the next sonographic finding I will talk about is the echogenic bowel. As we heard before in the first slides, the bowel has to be of an echogenicity which is below the echogenicity of the fetal bone. Sometimes meconium peritonitis is the reason for echogenic bowel situation. And when we talk about hyperechogenic bowel, we also have to know that we have to orientate ourselves on the ejected fetal bone. When the bowel is brighter or whiter than bone, echogenicity is elevated. If it is below the echogenicity of the fetal bone, it's normal. In our clinic, we talked about the question, is an isolated echogenic bowel a sign for higher risk and adverse pregnancy outcome? And for a long time, we looked at all the cases of echogenic bowel and compared it to a control group and could find out that the risk of intrauterine fetal death and the risk of intrauterine growth restriction is elevated in the cases of fetuses where echogenic bowel is existing. And the fetuses which showed chromosomal anomalies or cystic fibrosis were excluded, which means that echogenic bowel is a sign which is brings the fetus not in a good situation. These are some pictures of a fetus showing echogenic bowel and dilatation of the bowel and gut. And this case had a very tragic outcome because the baby, the mother came to the delivery room in the 38th week and no ultrasound has been performed, or let's say no ultrasound pictures have been stored of the situation when the mother went into the delivery room. The delivery on the vaginal route was very complicated. The head was born, the thorax was born, and then the baby was stuck because the fetal abdomen could not be delivered due to very massive power which was brought to the fetus to get him out. A rupture of the bowel took place and the fetus died within the next 2 hours. And this was a law case, and the clinic was lost this case, and high amounts of money have been paid to the mother. The next malformation is a very seldom. Here are photos from the 14th week of gestation. If you have a detailed look on this fetus, you see that there is something in front of the abdominal wall. You also see that there is a bending in the vertebral column, and by using color Doppler sonography, you can see massive movement and massive blood flow out exteriorated of the thorax. And this is a very seldom malformation. It is called the pentalogy of Cantwell, which is defined as a supraumbilical omphalocele, and the defect of the anterior and central tendon of the diaphragm, and the defect of the pericard, and the cleft in the lower parts of the sternum, and cardiac anomalies. And in this case, it was the most advanced form of Cantrell. There was also ectopia cordis. This is a situation which can hardly be solved by neonatal surgeons and fetal cardiac specialists, so that in that case, most of the time, termination of pregnancy is a way the patients can go. The next malformation is also very seldom. It is called the body stalk anomaly, or synonym short umbilical cord syndrome, or limp body wall complex. This malformation is only 1 out of 10,000 pregnancies, and it is characterized by the presence of major abdominal wall defect and severe kyphoscoliosis and the rudimentary umbilical cord. You see here pictures of the 16th week. You see a very mysterious shaped lower extremities. You see that the fetal abdomen is very much adjunct to the uterine wall. You see a normal amount of amniotic fluid. But by using the vaginal sonography, you see that the fetal abdomen is always in direct position to the placenta and the uterine wall. And this finding, without being able to demonstrate the normal umbilical cord, is characteristic for this very seldom malformation. And now you see pictures from the Department of Pathology, where you see that the whole contents of the fetal abdomen, there is the end of the fetal abdomen context, and there is direct adjunction to the placenta, all in a amniotic sac. You see that the mysterious shape of the lower extremities, which are bended for 180 degrees due to the enormous power of which was developed by being fixated to the placenta. Also in a better picture, you see this junction between placenta, uterus, and fetal abdominal contents. A second case in the 14th week, 13 plus 4 weeks. Also here you see the malformation of the fetal spine, the direct junction to the placenta. You cannot see any umbilical cord. Also in this case, the abdominal wall malformation complex. The next malformation I will talk about is the esophagus atresia in cases where polyhydramnion is combined with the absent visualization of the fetal stomach. You have to think on esophagus atresia. Sometimes the stomach bubble is very small due to the fact that a fistula between trachea and esophagus can bring the stomach to a small amount of filling. Sometimes in cases of esophagus atresia, you see a small echo-pore structure in the upper part of the fetal thorax, the esophagus pouch. I have never seen this, only in textbooks, not in real life. I hurried up in order to speed my presentation, and this is the last case from everyday life in our clinic. It goes back to the year 2014. A very obese woman in the first trimester came to our clinic. I saw echo-pore structure in front of baby's belly. A few weeks later, and using the vaginal sonography, this echo-pore structure in front of the belly is surrounded by vessels from the umbilical cord. In this echo-pore structure, some echo-rich parts of the bowel could also be seen. It was very hard. No exact diagnosis could be done at this stage of pregnancy. In the 14th week, here you see again the echo-pore structure in front of the fetal abdomen. 2 weeks later, on the lower part of the fetal spine, also an echo-pore structure could be seen, comparable to a small vertebral column defect. And at that time, the bells rang, and we came to the diagnosis of an OAES complex. OAES, or EEC, as it is called in the English language, is an association of different malformations: omphalocele, extrophy of the bladder, anal atresia, and vertebral defect. Also an extremely rare malformation, between 1 out of 200 to 1 out of 400,000 deliveries. In this malformation, there is also cloacal extrophy and omphalocele combined with imperforate anus and spinal defect. This malformation results from mechanical disruption or enlargement of the cloacal membrane. The timing of the rupture determines the severity of the malformation. Reason is unknown. Genetic and environmental factors are made responsible, but nobody knows the truth. In this case, in our clinic, a multidisciplinary counseling with pediatric surgeons and neonatologists was performed. An informed consent from the mother was obtained. The mother opted for termination of pregnancy, and this is what we could find at the Center of Pathology. the big ecopore structure in front of baby's belly ruptured during delivery. This is the remaining situation of the umbilical cord. You see that from this area the ecopore structure came, and here you see a very seldom situation. This is called scrotum fissus, and you see that here is no anal opening cannot be seen. This is as anal atresia and scrotum fissus. And the if you put a small metal thing into the urinary bladder, you see that the urinary bladder is in direct association and in direct continuation to the fetal bowel, which is also from the cloacal malformation, which I've talked before. On the back side of the fetus, you saw as a dimple in the skin, but opening the skin, you saw the very large defect of the fetal spine. Ladies and gentlemen, not to stress you too much in this very hot afternoon, I stop with my presentation, and I thank you very much for your attention. And if someone wants to have a discussion, I'm open for it.
Thank you, Professor Bettelheim. It was very, very interesting, a sophisticated presentation about quite rare anomalies, but it's important to see it, how it's looked like in a real life. And I will postpone discussion to the end of second lecture because we are running of time due to the technical problem from the beginning of this webinar. So I would kindly invite our next honor speaker, Professor Nicolae Suciu from Romania University of Medicine and Pharmacy in Bucharest, and he is well known in the field of gynecology and obstetrics, especially in minimal invasive surgery. He was a founding member of the Romanian Society of Minimal Invasive Surgery, and he was a general manager of the National Institute for Mother and Child Health for more than 10 years. So, dear Nicolae, we wish you very warm welcome, and please give us a lecture about the intrauterine therapy, current and near future perspectives. Please.
Dear Mrs. Tania Grusevich, dear distinguished audience, dear Professor Dieter Bettelheim, dear Professor Barfai, I would like, before to try to share with the audience my presentation, I would like to thanks to organizing committee to share about the latest knowledges, not in intrauterine surgery, but about intrauterine therapy, because it's two different means of the these two topics. And I am very glad to be at this webinar of Diczfalusy course. I was honored to attend the many meetings that this foundation organized in memory of the established Professor Diczfalusy and his wife. And now I will try to have a I put in my presentation the latest and I hope the updated news regarding these topics. The objective of my course is current intrauterine therapy, TTTS management, and of course we have to accept the limitation and the benefits, fetoscopic treatment of congenital diaphragmatic hernia and spina bifida aperta, future intrauterine therapy, research in this field, the latest orientation in research, and some home message. For fetal surgery, there is some rationale that recommend the treatment for the disease that are not compatible with either prenatal or postnatal survival, or the treatment of the disease, as I mentioned here, could be with a detrimental impact on postnatal treatment option when it is postponed for prognosis, and of course what we all we are waiting, the family is waiting, the quality of the life on newborn. Minimally invasive intraamniotic, as the name means, minimally intraamniotic fetal access for both for mother and for fetus, or with the multiple pregnancy, the fetuses. And of course, we have to take into account some aspect of maternity, because this binomial maternal and fetal morbidity, to talk about this. Overall is, as I mentioned, a minimally invasive intervention with less than 5% of maternal bleeding, infection, and miscellaneous. There is a data that count that amniotic leakage could happen at the mean of 30 weeks age of gestation, and but most of the fetus, that is more important, are born beyond the 30 weeks of gestation. But we have to recognize during the even we call minimally invasive procedure, especially for TTC and the cardiac intervention, the fetal demise is quite high, 1/3, about up to 30%. But fortunately for this kind of a procedure, fetoscopic repair of the spina bifida aperta, the fetal demise is less than 2%. That is a very good point of which recommends this kind of procedure. Prematurity commonly derived from preoperative problems, but it is a consequence of, and we recognize that is prematurity could be a consequence of the in utero surgery. But
Nikolai, excuse me, there is no slide.
No slide. It's not.
No, we can't see any slide.
Yes, I put already. I moved the slide. Just a moment. But Ivan, you have to assist us.
So what happened?
Yes, I'm here.
We don't have
You will have to the same just before.
Because it's a nice presentation, but you know the slides would be.
Ivan, can you help to share the slide? Doesn't matter. I try to keep my to talk about the.
Because it was working just like.
Do you see now something?
No, it's you on the picture.
You know what?
I don't know why. Share, maybe.
Okay. Open share tray, desktop window, and now.
Yes, it's the same.
So you cannot see us. You cannot see the slides.
No, you are on the screen now. Your camera.
Your camera.
Why, I don't know.
But did it work before?
Did work before?
It worked before on the try. It was perfect, but now we can see you now. Only you, not the screen.
So I put open share tray, desktop window.
Yes.
And now you cannot see. No? You cannot see now.
No.
Why is it not working? If it works on the.
I don't know why.
Okay, let's see. Now
No, it's not. Wait.
No,
Now it's okay.
It's okay. It's okay.
Now it's okay.
Okay.
No,
Yes.
it's okay.
Okay, I'll try to talk again. Yes? No.
Just show the slides.
I would like to,
Yes.
to
Yes.
show
Yes.
again.
Yes. I will cut the other one from the movie. It's okay. You can start.
Now it's okay.
Yeah, it's okay.
You are on the
rationale for fetal surgery, 2 reasons at least, and we talk about the fetoscopy as a minimal invasive intraamniotic fetal access, minimal invasive for both mother and fetus. Overall, the complication for mother and fetus is minimal. Maybe some maternal bleeding, infection, or different other symptoms. Sometimes we have to accept that after the in utero intraamniotic procedure, the amniotic fluid leakage to be ruptured at 30 weeks. But most fetus, this is more important, are born beyond 30 weeks of gestation, but except some undesired things that the fetal demise, like in TTC or cardiac intervention, could rise up to 30%. Comparable when we are compared with fortunate with only less than 2% in spina bifida repair. As I mentioned, prematurity commonly derive from preoperative problems, but commonly come from because we incriminate the minimally invasive surgery, but the preoperative problem is in of the comorbidity of the pregnant women or maybe with the fetus. In this paper published by Ivesville in 2004, which represent in fact the benchmark for laser ablation, which recommend laser coagulation of anastomosis is more efficient and effective as a first-line treatment for the twin-twin transfusion syndrome before 26 weeks of gestation. Being in Creta at the FMF annual congress, I have heard that many teams from different hospitals already have tried to do this procedure a little bit lower, around 20 or around 20 weeks of gestation, with the benefits for the fetus and of course for the mother and for the pregnancy. Sorry, the main acceptable technique in laser strategy in twin transfusion syndrome is Solomon technique, which imply equatorial section of the placenta, which is considered the most efficient. A shot with the fetoscope laser ablation TTC, and another undesired situation, amniotic band constriction, is a condition that is extremely rare, but with devastating consequence if you do not treat or to have a positive attitude. Another indication for and a very useful procedure could be a fetal blood sampling. There are current common indication from diagnose and treat fetal and fetal severe anemia, diagnosis and evaluate therapeutic response of neonatal alloimmune thrombocytopenia, and of course sometimes not like common indication in evaluate non-immune fetal hydrops. But besides this, from historical or less common indication, we can talk about fetal as an indication for fetal blood sampling is fetal aneuploidy for karyotyping, determining the fetal blood type and platelet antigen status, diagnose genetic disorder, and or measure the biochemical or other serum markers, but all are this practice are in fact replaced, but the new one as CVS or amniocentesis or NIPT that could more even molecular testing for the benefits of the fetus. Fetal blood transfusion is I present here how to organize, to set up the procedure after measure the difference that could have a success. We do transfusion straight in the heart, and we of course we have to take into account the amount, the blood that we have to give to the fetus. Another condition that can be usually is diagnostic in the second trimester is lower urinary tract obstruction, which and as others few need amniotic shunting because if it's too late, this condition could compromise the kidney function, and the fetus is is not in a good condition, and many after the cancer in the family, many family have a TOP option for the fetus. About the fetal shunting as an indication, as I mentioned, lower urinary tract obstruction. Sometimes we have immune or non-immune pleural effusion, fetal hydrops, and of course the undesired congenital cystic adenomyoid malformation or bronchopulmonary sequestration. Here we have open procedure that I shot it from a few years ago in 2003, but regarding CDH, congenital diaphragmatic hernia repair, but new technique has emerged with at least the same benefits, but some of the new technique offer more benefits, especially through the neurocognition and the well-being of the fetus with this kind of anomaly. As a complication and the indication for endoscopic fetal surgery, complication of the monochorionic twins, which happened because quite frequently because the many couple postpone to have a natural or other reason to have children, and they ask to assisted reproductive technology, and sometimes the multiple pregnancy could be a link for this kind of procedure, as I mentioned, especially to TTC complication. Another endoscopic fetal surgery that we have to do on time till do not worsen the well-being of the fetus is congenital diaphragmatic hernia, spina bifida, or maybe the tumors regarding chorioangiomas, sacrococcygeal teratoma, or, as I mentioned, low urinary tract obstruction. And of course, stem cell therapy is ongoing. New hopes for improving of the well-being of the fetus. Congenital diaphragmatic hernia with, especially on the left side, almost 85%, only a few on the right side. What is important to know when we have a diagnosis of CDH, that we have to keep in mind, is not so frequent, is sporadic, one case on 4,000 births, but we have to keep in mind that almost this anomaly CDH are associated with chromosomal or other abnormality as a cardiac or central nervous system, renal, or even bowel atresia. What is important in congenital diaphragmatic hernia when we choose to proceed to intravitoscopic procedure is important to measure the ratio between lung, two diameter of the lung, and the ratio with the head circumference, which situate the indication and give our the prognostic hopes. If usually if it is the ratio is under the 1.4, the prognostic is quite not good, but around 1 is very, very bad. In this paper, in this slide, I wanted to present the fetoscopy endoluminal tracheal occlusion that was introduced a long time ago, and now is performed through fetoscopy and especially through laryngoscope of fetoscope, and the latest, as I will try to show later, the latest technique got more practical skill how to minimize the injury of the fetus. In this slide, I immortalize a procedure for who trying to solve left congenital diaphragmatic hernia at 27 weeks of gestation, direct fetal laryngoscopy, and of course as I mentioned, was important to choose the proper time, the proper age of the fetus till do not get alteration or some bad things regarding the life after delivery. Researcher, different teams now are try to answer to the challenges, problems. Especially there is a very known team in Strasbourg, which the leader is Professor Dr. Basurto, which try to rescue pulmonary hypoplasia, reverse the occlusion, and they use an intact balloon which is spontaneously expelled out of the airways using MRI device, which has a very strong magnet which detach and expel the balloon from the air of the fetus. It's important, of course, as the team of the Dr. Mrs. Francesca Russo try to propose. It's important the ratio of the lung to head ratio. Liver position is the one of the most important sign that you have to take in account, the position of the stomach, and of course additional test offered by MRI, or of course do not have to keep in mind the genetic testing, because till 33% of the patient, the newborn with congenital diaphragmatic hernia, could get cytogenetic aberration. Another idea that arise from the research, because we have to follow the recommendation for the researcher team, was that we have to reassuring long-term quality of life of the newborn. But as he has mentioned in his quite good paper with the cohort was included around I think 18 patients with CDH. We have to standardize the in literature have to standardize how the screening exam require, and the appropriate, as I mentioned, timing for evaluation, and to solve the procedure with the minimal consequences of the neurosystem and the cognition of the fetus. As I mentioned, one of the bad things that we have to put in account is neurodevelopment dysfunction due to the CDH. One of the most common comorbidity is happened when the position of the liver is up, as Professor Hendrik and co-worker demonstrate that the neonate with intrathoracic liver position had a mortality approximately 55%, and almost three-quarter of them, 80%, require to be assisted by ECMO system. On the other hand, the dancer and co-worker reported that more than 2/3 of the CDH children with prenatal diagnosed intrathoracic liver position had delayed neurodevelopment function. For this reason, some team, especially the team from Strasbourg, recommend to perform CDH repair procedure as before, not to wait till the neurodevelopment dysfunction could leave non-benefits on the cognition of the fetus. I try now to talk, to have some words regarding spina bifida and cerebral changes. Is a disease with incidence which differ from United States to Europe. In the United States is the frequency, the incidence is around 4% for 10,000 live births, and in Europe, neural defect is around 2.3 per 1,000 live births. Of course, some benefits come from the nutrition supplements that was added in the alimentation in the United States, and of course we have to promote these prophylactic supplements to diminish the consequence of possible to affect less new fetus. One good thing is that about spina bifida, prenatally diagnosed is around 80%, comparable with bilateral renal agenesia, posterior urethral valve. So we can manage it quite properly, and to give to the fetus and the family the hopes to come in the life with hopes and without as less injury. There are some risk factors as probably from history, maternal diabetes, maternal obesity, of course, could happen prenatal exposure to valproic acid, or possible lower vitamin B12 level during pregnancy or before, maternal periconceptional opioid use, and chronic low-dose radiation exposure or anti-malarial drugs during, especially in the first trimester. There are two theory, two hypotheses: embryologic malformation, first hit, and the secondary is damage could happen. Here is some picture regarding how look intra-fetoscopic evaluation after detailed ultrasound, which show the chemical damage come from the pH of the amniotic liquid could cause damage to the myelin, to the neurostructure, which are exposed to the pH of the amniotic fluid. This is an example of spina bifida on scan, which show the meningomyelocele on the MRI and sketch. Yes, and what is important, and the fetoscopy procedure to get a good skill in and the practice and knowing that the fetal neuroendoscopy in spina bifida is has to be the high standard, because could compromise the movement of the legs, and before to do the procedure, the practitioner the surgeon has to be sure that the fetus is in a good condition. Very useful for this diagnostic was remarks of Professor Nicolaides' teams in around 1980, when they promote the lemon and banana sign on the ultrasound of the cerebral ultrasound. Here I retain this picture because this is try to unify theory, the pathogeny of the chiaridoid malformation, and how it could be solved after the procedure in utero with quite the same results as in open surgery. Of course, the minimal invasive fetoscopic surgery for spina bifida is a very meticulous procedure, consuming time, but we are sure that the fetus and his mother and his family deserve to restore the integrity of the defect. Doesn't matter at which level of spina bifida. Here, we recognize that after we close by surgery and using a patch, biological patch at the end of procedure, now there is a suggestion to close the defect in not only on one layer, even in 2 or 3 layer, which offer more protection and show the preliminary data show the good result. Fetoscopy means minimize maternal trauma, not only the fetus, delivery of the fetus sometimes are by a cesarean section, but 85 from the data that I got it, 85 babies delivered at or beyond 30 weeks of gestation, and of which 50% of babies was delivered beyond 30 weeks. Is important which category of the prematurity are this patient, the fetus, to offer them the chance to adapt to the out of uterus life. Of course, after delivery, after the birth, there is a postnatal infant care. Sometimes could need some surgery, aesthetic surgery, and to keep healthy the place where was suture. Regarding the fetal outcome after fetoscopy fetal surgery, was a study from 2000. Yes.
Sorry, please, just to know that we have to finish in 5 minutes, so please.
Yes. Okay. Yes. No, only few demise, and the reversal hindbrain was almost, and only 45% of the spina bifida repair needed to get after soon after and reintervention in the first 3 years. Another way to solve this problem is laparotomy assisted fetoscopy, which offer equivalent fetal benefits with minimized maternal morbidity. Or, of course, we have to improve our optimal technique. A retrospective cohort study of 55 women screened from 2017 to 2019. Fetoscopic closure was completed in 84%, and in utero hindbrain herniation improved in this cohort of 86%, and spontaneous rupture of membrane occurred in 31%. and at the age at birth was 37 weeks, and 50% of 16 women delivered at term. Vaginal, not surprisingly, but maybe for someone, vaginal birth was achieved in 56% of the patients who accepted to be solved through laparotomy assisted fetoscopic repair. Percutaneous mini laparotomy fetoscopic repair offers some benefits close to the open surgery, but of course minimally invasive, with the benefits for fetus and the mother. And percutaneous minimal access fetoscopic surgery for spina bifida can be performed with a high rate of technical success in regardless of the placental position. Flexible fetoscope could offer some benefits for especially for TTC syndrome, but another benefits come. Fetoscope is the latest device that we can work with it, but this flexible fetoscope is very useful for vasa previa type 2, which could offer opportunity for the pregnancy to be close to the term. Another in utero procedure would be stem cell transplantation, which offer multiple therapeutic advantages, which fetal stem cell therapy provide access to hematopoietic stem cell niches at an important time in development when the stem are migrating to their destinated tissue and offer the ability to treat a disease before birth. And of course, benefits come from hematopoietic stem cell for in utero put in intraamniotic fluid, especially for some immunodeficiency when is justified, and the benefits grow to conform with the latest data to 97% of the cases. As I mentioned, the benefits of fetoscope laser ablation in type 2 vasa previa, which prolongs the pregnancy close to the term. Another benefits, therapeutic benefits, come to extracellular vesicle, which are self-reproduct, potentially capable of modulating the inflammatory microenvironment, which have growth factor, microarrays, and other bioactive molecule. There is a two study that recommends this kind of extracellular vesicle to be instillated in the amniotic fluid, with the benefits for do not postpone till after the delivery. A few words about the last topics that I want to share with you: artificial placenta. Several major research laboratory currently working on development on artificial placenta. This is now in the study of a laboratory. What is important to know the artificial placenta? That is extracorporeal circulation designed for elegance, maintains a fetal circulation, fluid-filled lungs, vascular access, and specialized environment for organ protection, especially the neurocranium. there are two studies which demonstrate the benefits for lamb by using artificial placenta, and the last slide is that there are many intrauterine therapy that are promising. Maybe the latest that I presented in my presentation, with extracellular vesicle, hematopoietic stem cell transplantation, and maybe for the with other benefits, artificial placenta are a particular interest. And of course, protocol, some of them must be standardized, and the fetus with congenital diaphragmatic hernia need a better strategy in order to assess long-term outcome of this quite bad condition, which is CDH, congenital diaphragmatic hernia. Thank you very much, and I would like to thanks for understanding me for I extended my presentation, but maybe I will try to sensibilize the audience for the new idea to search and to be in touch with the latest development for the benefits of the fetus, the mother, both, and the family, because this family, in fact, is our main purpose.
Thank you. Thank you for both speakers. It was very interesting, but we are running out of time. So I think that probably discussion, maybe we can organize through emails if there is some questions, and probably in the future, in some meetings which will be organized face-to-face, we can discuss about this interesting and very important subject. So in my personal name, in name of the Diczfalusy Foundation, and for our main sponsor, Richter Gaydon Company, I would like to thank to all participants, especially our speakers, and I wish you a very successful summer, nice holidays, and we continue in September. Thank you. All the best.
Thank you.
Thank you very much. I would like to say a few words. First of all, thank you very much for the chair lady and for the speakers. And as Anna mentioned, you know, there is room for question by email, and both presentations will be available on the internet. So I encourage you to go through again and send email to the speakers if you wish. And congratulations. And I join to Anna, and I wish you a pleasant and successful and relaxing summer holiday.
Bye to all.
Bye bye.
Bye bye. Thank you. Thank you for supporting to Ivan, for supporting us technically. Thank you.
Yeah, thank
welcome.
you very much.
Welcome.
Bye bye.
Thank you. Bye.